Good morning, everyone. Can you see my slide? Hello.
Hello, Amna. Assalamu alaikum. Hi, Amna.
Assalamu alaikum.
Salam alaikum.
Yes, we can see the doctor. Thank you.
Shall we start? We can see your slide.
Dr. Amna, can you hear me?
Yes, I can hear you. السلام عليكم.
عليكم السلام. والمحاضرة واضحة؟
هي السلايد واضحة. هي أمنا.
أوكي.
يلا بسم الله.
وأنا طالعة بالصورة. أوكي.
أوكي شفناك يلا start.
يلا. Okay, so good morning, everyone. Today I'll talk about chronic lung disease. My name is Dr. Amna Alzaabi. I'm an ICU consultant in Fujairaj Hospital. My lecture, sorry for that, but I will divide it. I took the permission from Dr. Amna. I will divide my lecture to two. First, I will talk about the outline, definitions and pathogenesis of the disease, and next lecture it will be more details about the management of the chronic lung disease. So outlines of the lecture, it will be we'll go through the definitions of the bronchopulmonary dysplasia, and then we'll talk about the epidemiology, the physiology, the pathophysiology, risk factor management, guideline for prevention of bronchopulmonary dysplasia, and the long-term outcome. So can we agree on definitions of the chronic lung disease? We know that bronchopulmonary dysplasia is a condition of chronic lung disease due to disruption of pulmonary development in a preterm infant. So what's the difference between bronchopulmonary dysplasia and chronic lung disease? Bronchopulmonary dysplasia, as a term, we use it more for the preterm babies with the disruption of pulmonary development or chronic lung disease, and the chronic lung disease is more broad spectrum or broad definitions that use for even term baby with the lung hypoplasia, or term baby with diaphragmatic hernia and respiratory insufficiency. So the chronic is more broad, and the bronchopulmonary dysplasia is more to the very preterm babies. So before, what we know at what we call it the clinical definitions of bronchopulmonary dysplasia, defined as requirement of oxygen supplement either at 28 days postnatal age or 36 weeks postnatal age. This is what we know it, and what they agree on it for several times. So this definition, if you can see, it goes through a lot of modifications, multiple modifications, to reflect the changes in patient population, and also to reflect the better outcome, and also with the new modalities of the respiratory support. So we can go, the definition initially started on 1961. So they defined the bronchopulmonary dysplasia as progressive clinically and radiological changes. Okay, by Shinan in 1988. In 1988, their single center retrospective study showed that continuous use of supplement oxygen at 36 weeks post-menstrual age, it will be more reflecting or closely associated with abnormal pulmonary findings with high morbidity, and also upon long-term follow-up in infant less than 32 weeks. So at 36 weeks, it will reflect more the outcome. It will reflect more the pulmonary findings. But these definitions again go through a lot of modification. So on 2001. This is what we know it. They define it as oxygen supplement either at 28 days or at 36 weeks post-menstrual age, and they start grading the bronchopulmonary dysplasia to mild, moderate, and severe. So here the grading is still only depend on oxygen supplement. So they said the mild one, patient room air at 36 weeks post-menstrual age or at discharge, which coming early. Moderate patient required oxygen but less than 30%, and severe patient required oxygen more than 30%, either in positive pressure, IPPV, or invasive or non-invasive ventilations. And they divided population to less than 32 weeks or more than 32 weeks. They said required of oxygen 28 days or but 56 days postnatal age or at discharge, which coming first. So this is the old definitions in 2001. Now they go to different definitions. In 2016, I felt it become more complicated. They combine the oxygen supplement with the respiratory support. So they define the mild cases, either patient on nasal cannula or patient on CPAP or NFPC, but the FI2 requirement become different. So for example, if he's on NFPC, which is non-invasive ventilations, the FI2 around room air. If he's on nasal cannula, around 3 liters or less, between 22 to 29, and if he's in 1 liter or less than 1 liter, from 22 to 70. This grading, for me, it looked like a little bit complicated. They make it more simple in 2019. So in 2019, they removed the oxygen supplement. They found that the oxygen supplement, it's not predicting the outcome. So they go with respiratory support. So the mild cases, any patient on nasal cannula less than 2 liters, a moderate patient on high flow nasal cannula or on CPAP or NFPC, and the severe, they kept it only for invasive ventilations. So this is the latest definitions of the bronchopulmonary dysplasia, and this is done on the latest study on 2019, and I think the one who did it is the same person, which is Shinan. Okay. Now I will go to the epidemiology. So why I choose this topic? We know that more than 40% or 45% of the very low birth weight, they end with either mild or moderate or severe grade of bronchopulmonary dysplasia. And we know that this is very common problem and affecting, as I mentioned, more than 40% for the population less than 29 weeks, and the risk of the bronchopulmonary dysplasia increase as with decreasing the gestational age and birth weight, and it's more in the Black population. I can show you. Okay, so I can share with you this the incidence of bronchopulmonary dysplasia. And you can see that 90% of the 22 to 23 weeks, they will end with 1 degree of bronchopulmonary dysplasia. Then 71% between 24 to 25. Between 24 to 25, 70% they will end with bronchopulmonary dysplasia, and the gestational, like by 28 weeks, only 20% they will end with bronchopulmonary dysplasia. Just can I pause for a while? Sorry for that. Okay. Yeah. Sorry. Okay. So now, if you go to the incidence of the if you go to the incidence of the bronchopulmonary dysplasia, as you can see, there is as the patient going smaller, as the patient having more incidence. Sorry, I forget this one. This one is showing that the patient with less than 760, they have more high incidence of bronchopulmonary dysplasia, and as the patient having good weight, he have less incidence of bronchopulmonary dysplasia. Sorry for that. Okay, so here you can see this is taken from the American Journal, done on 2018, and they combine the oxygen supplement at 28 days plus at 36 post-menstrual age, and you can find as the gestational age, it's disproportion inversely. So as the patient low in gestational age, they have more incidence of chronic lung disease. Okay, now we'll go through the risk factor of the chronic lung disease or bronchopulmonary dysplasia. And risk factor, you can divide it between antenatal factors and postnatal. So antenatal factor, you can see that the placenta insufficiency, lack of antenatal steroid, or smoking mother, or chorioamnitis increase the incidence, or it's a risk factor for bronchopulmonary dysplasia. Postnatally, as you know, this baby transitioned from low oxygen environment to a high oxygen environment, and need for supplement oxygen as well as inadequate antioxidant mechanism. All this play a role as postnatal, so ventilation wise and oxygenation wise. So we can say that postnatal, if the baby is male, we said more in black population, and more in patient with genetic susceptibility or genetic predisposing factors, or the patient born with sepsis, or he had sepsis later on. Now, mechanical ventilation, it play a major role because high tidal volume, or we call it volume trauma, or high pressure barotrauma, or low PEEP, or it's keeping by over distension and then atelectasis. All this can lead to chronic lung disease. And also oxygen itself, when you are not targeting the oxygen, like you keep the oxygen in higher side, also it can lead to more oxygen injury, more damage, and this is lead also to chronic lung disease. Okay, so now I will go through the pathophysiology, but before we go to the pathophysiology, we have to know what's the lung stages, and this is very important for the NICU fellows. You have to know that the lung going through 5 stages, and most of our population born between canicular saccular stage, because most of them is born either in 24, which is the end of the canicular stage, and beginning of the saccular stage. So there is a lot of factor that can change the fetal programming and predisposing this fetus or this neonate to chronic lung disease. For example, patient IUGR, or low nutrition, or placenta insufficiency, or maternal illness, or mother did not receive any steroid. All this, it will affect the outcome. And later on, if the patient it will affect the outcome, so it will lead to more inflammation, more oxidant injury, and with the mechanical ventilation and oxygen and poor nutrition, all this will predispose this patient to chronic lung disease changes. So again, I will go to the pathophysiology. The pathophysiology or the factor that lead to lung injury. So first is the abrasion in the normal lung development. And I mentioned before the antenatal factor and postnatal factor that can lead to this abrasion or disruption of the normal lung development. There is also another theory, they call it lung angiogenesis or vascular hypothesis of the bronchopulmonary dysplasia, and there's imbalance between pro and anti-angiogenetic factors. And if there is imbalance between them, it will lead to more impaired vascular growth and impair the function, or بالتالي it's impairing the alveolizations. There is another theory of exposing this fetal lung to infection like chorioamnitis or later on sepsis. All this, it will trigger the inflammation cascade and the interleukin, and this will lead to more of lung injury. Other theories also is the effect of PDA. You know that PDA, it's lead to left to right shunt and more pulmonary blood flow and more the lung fluid increase, and this is negatively affecting the lung mechanism and gas exchange. So we are only targeting the significant hemodynamic significant PDA that can lead to more pulmonary edema, hemorrhagic type of pulmonary edema, and more worse of PBD, chronic lung disease. Other things or other factor that can trigger the inflammation cascade and leading to more lung injury is, as I mentioned, antenatal infection, ventilation, excessive tidal volume, oxygen free radicals, and postnatal infections. Other things that I want to mention it also, there is a lot of mediators or factors that lead to worsening of lung injury and bronchopulmonary dysplasia, and they found it more in the tissue with the patient with PPD, such as connective tissue growth factors, vascular endothelium growth factors, fibroblast growth factors, and insulin growth factors. So imbalance of these mediators, it can lead also to further worsening and lung injury. Now we have to move to differentiate between, sorry, this is the last. So we say that there is antenatal factors such as IUGR, chorioamnitis, bacteria, colonizations, maternal smoking, and prematurity itself. And there is also postnatal factors such as ventilation, oxygen, infection, and PDA. All this can lead to lung injury, impaired development, more damage to the vascular matrix, and more damage to the alveoli and capillaries. And this will lead to respiratory failure and early death. I saw many cases when I was working there, early death of the patient from severe chronic lung disease. So, and this will lead to abnormal repair and abnormal regenerations. And this abnormal regeneration, it will end with bronchopulmonary dysplasia. So this is the main theory. I mentioned it in the pathogenesis of the disease, which is lead to decreased septation, alveolar hypoplasia, and dysregulation of pulmonary vascular development. Now I will move to the most important, this is almost the same slide that you can see the pathogenesis and the pathology of bronchopulmonary dysplasia. Now what we have to know is what's the difference between old bronchopulmonary dysplasia and the new bronchopulmonary dysplasia. So we have to differentiate. This is old, it's the before the surfactant. They call it pre-surfactant time, and this is the new one, which is post-surfactant. So let us differentiate between the old and the new. So the old, most of the population was moderate preterm infant, and the new is extreme preterm infant, and this is due to improve the survival of the extreme preterm infant and improve the respiratory support and the nutrition. So we can say this is the old is pre-surfactant era, and the new is post-surfactant, and the old one is characteristic by that prolonged ventilation with high oxygen and high pressure, which lead to severe airway injury, lead to severe alveolar edema, intense airway inflammations, and lead to more fibrosis and more metaplasia of respiratory epithelium. The new PPD, they have less fibrosis, we can say arrest acinar development, less prominent inflammations, less fibrosis, but they correct the character of alveolar hypoplasia or with what we call it. Yes, so you can differentiate that it's alveolar simplifications with fewer and dysmorphic capillaries and less evidence of emphysema, less airway damage or vascular remodeling. So the new PPD, we can say it's less fibrosis and less emphysema comparing with the old one, and we can see it here on the X-ray, and we can differentiate. Both of them is worse, but I think the new one is more homogeneous. Now, I said that I will complete my management next week, but I want to talk a little bit about the prevention. So next, my lecture, it will talk more about the ventilation modalities and management, but now let us to talk about how to prevent. Can we prevent, or at least can we reduce the severity of chronic lung disease? And instead of severe, we can make it mild to moderate. So first, I will mention about antenatal steroid. It's important that the patient, any patient, very low birth weight, to receive steroid antenatally. Then please, early CPAP. So we found that non-invasive or CPAP decreased lung injury, the barotrauma and volutrauma, and there is a meta-analysis showed reduce in bronchopulmonary dysplasia or death, supporting use early CPAP. And I think many units now, they use CPAP from the 0 minutes, from the first birth, and there's portable CPAP available in each delivery room. Then we will move to oxygen saturation target. Okay, this is also important that your monitor should be kept in certain target oxygen. I will not talk because each unit having here, but here in our unit we target between 90 to 94, and we keep our monitor between 89 to 95. So this is our protocol here in Fujairaj Hospital. So they found increased mortality, but no difference in the rate of bronchopulmonary dysplasia if the rate keep between 85 to 89. And now we decide to target, and the recommendation to keep it in low 90s or 90 to 94. Early surfactant, please, if the patient needs surfactant, so early better than late. What I mean by early surfactant, it's between the half an hour to 3 hours, okay? Then you give it later on. But now we are targeting the patient, not all the patient we intubate them. The patient that's showing high FI2 requirement, showing ingoing RDS, they are the only cases that we intubate them either through the Ensure technique or less invasive technique like LISA or MIST. So depend on your protocol here, because we don't have the catheter, so we are using Ensure technique. So most of our populations, like 26 and above, we use Ensure technique if they require to intubate it. Then we'll talk about early caffeine, and now we are using caffeine for any population less than 30 weeks. 30 weeks, and some of the unit 28, we are using caffeine from 0 hours. So it's a part of the golden hour. We are putting the caffeine. So early caffeine. So it's found to reduce the duration of mechanical ventilation by improving respiratory drive and improving the tidal volume, lung compliance, reducing the total lung resistance, and also it works as anti-inflammatory and diuretics effect. So use early caffeine associated with a 30% decrease in bronchopulmonary dysplasia. Early caffeine use in the first 10 days, it's recommended. Now, vitamin A, it's different from unit to unit because the study showed that injectable, the intramuscular administration of vitamin A, it's recommended to reduce the incidence of bronchopulmonary dysplasia. Really, Anna, I came from unit, we never use vitamin A because it's not the incidence of chronic lung disease, it was low, and the patient need to be treated it's not significant. That's why we never use vitamin E injection, and it's painful procedure, and it's 3 times per week. So I will stop at this point, and inshallah next lecture I will go more details about the ventilations strategy for reducing chronic lung disease, and also I will go about the therapeutic management of chronic lung disease. Sorry for that. Any questions?
Thank you, Dr. Amna. I'm Dr. Yamin from Qasim Children's Hospital. Fellowship
Yes, مرحبا دكتور
third
يامن.
year. أهلا وسهلا. عندي question regarding the prevention for the usage of postnatal steroids. The second is the fluid restriction to prevent BPD. Thank you.
أنا دكتور يامن أنا مخبتنها السلايد. You know, this is the next slide. It's about postnatal steroid and antenatal steroid and diuretics. أنا خبيتها لأني I want to talk more details about it on the next هذا. So now the recommendations for the fluid is better to restrict 140 to 150, maximum 160, but with good nutrition, with good calories. So we can say restrict the fluid, but good nutrition, because the nutrition, as I mentioned here, I mentioned this one, the nutrition should be between the fluid should be between 135 to 150 ml per kg per day, with calories around 120 to 144, or some of them they said even 150 calories per kg per day. Early aggressive parental nutrition and good nutrition, it will help a lot on reducing in reducing the bronchopulmonary dysplasia. And I believe this is the only management for the bronchopulmonary dysplasia is good nutrition. Try to put him on non-invasive ventilation and CPAP, early extubation. And good nutrition, it will help a lot of population to go out from this disease without needing a lot of disease. So your question is about antenatal steroid. They said it's your question is about postnatal steroid. It's work as anti-inflammatory. We never use it early before 7 days because this can worsen the IQ or worsen the neural development. Usually, if we decide to use it, usually after 2 weeks. 2 weeks of age, so to avoid the side effect on the brain itself. Can I, Dr. Yaman, can I leave this one for the next lecture so I can talk more details and more evidence regarding this?
Thank you, Dr.
Welcome. Thank you.
Dr. Amna, I have a question, please. Regarding vitamin D, vitamin A. You mentioned that vitamin A, one of the preventive measures as intramuscular, but with extreme preterm, usually you start them on TPN, which is already including vitalipid. So yes. This is enough, or this is extra? This intramuscular specifically, they specify those, or what's your
so thank you for
point of view?
Thank you for your questions, yes, I agree with you. We are using the vitamins and intralipid vitamins in the TPN. That's why we said aggressive TPN measurements. But this is, I think, later on they use it as injectable doses 3 times per week. Really, I don't have an experience on that. Maybe Dr. Yasser from Canada, because they use it, maybe he can answer or help us. I hope Dr. Yasser.
Much for this nice picture, but for the vitamin A, it was according to what that we have mentioned earlier. Number needed to treat for every single intervention, you have to look at the number needed to treat. Here they found that every 14 babies will receive the injection for vitamin A. You can spare one from getting BPD. So they found from the number that it does not work it. That's why, you know, as a practice, they have studied the outcome from the use of the vitamin A as an intramuscular injection, like Dr. Riyam has mentioned. And according to the number needed to treat, from 14, you will save one, it doesn't work it. So it is not really the practice. Yani one of the modalities they have looked at in order to prevent the BPD.
Yeah, thank you, Doctora, for your comment. So again, it's recommended depend on the clinical incidence of primary disease.
Yeah, thank you.
Dr. Amna, can I ask a question? Thank you very much. Did you hear me?
Yes, yes, I hear you, Dr. Adel.
Yes, thank you very much. For very, very interesting, really subject and the topic. We appreciate you choosing a nice topic. My question: you have a policy to discharge the patient home on oxygen or not?
Thank you for that. Yes, this will be discussed on the next slide, inshallah, next lecture. I'll talk about home discharge home on oxygen. It will be with the next lecture. It's part of the management. Yes, there is few patients, we discharge them on home oxygen.
Dr. Amna, one more question, please. You said that you use the ensure technique in your unit. For your ensure technique in your unit, you give the Servanta and leave the baby on the ventilator, or within how many hours you extubate the baby?
The الشباب اللي جاب. So yeah, we give at the same time. So what this means, ensure technique, we intubate, we give Servanta, and we pull the tube. We are not connecting them to the machine. We are not connecting them to the machine. So in and out. Now I think the catheter, it was the request by Dr. Khalid. I think Dr. Khalid is here. Requested by Dr. Khalid, the Lisa catheter, and it will be available soon, inshallah, so we can use the less invasive surfactant administrations. Any comment, Dr. Yasser?
Dr. Amna, سؤال. طيب, if you are intubating a baby and you want to extubate immediately, this means that you will not be able to give sedation.
Pre-medication.
Pre-medication.
Yes.
Isn't it?
So you are intubating without pre-medication.
Again. Okay. We'll go. Yeah. There is some mic here. Can you close your mic?
Hi, Salam alaikum.
Yeah. So again, can I speak? There is mic.
So two things. First of all, regarding the Ensure and the Lisa, yes, the shorter the duration of intubation and mechanical ventilation is definitely the better, and less incidence of BPD. But I would recommend connecting the baby to the ventilator while giving the surfactant, rather than doing the PPV by using a bag. Because when you do the PPV using the ambo bag or whatever the use of TPS resuscitator, definitely you will not be able to completely control your PEEP and PIP and rate. So I would suggest like you can use the manual breath on your ventilator, pushing the surfactant in, and connect the baby to the ventilator during the intubation stage of the Lisa or the mist. Regarding the sedation, you still can do the RSI or the pre-medication. Excuse me. What we used to do is to use the 3 medications, which is the atropine and then fentanyl and then the succinylcholine. Well, you know, like the atropine just to keep the heart rate and to control the secretions. The fentanyl to sedate the baby. This is the one of concern. The succinylcholine, the muscle relaxant, the duration of action would not take maximum 1-2 minutes. So it's very rapid acting and very short duration of action. The problem is about the fentanyl. So definitely the pre-medication now is the standard of, should be the standard of care, as it shows decrease the incidence of IVH, the fluctuation in blood pressure. So the benefit is much, much better than not using the RSI medication. The problem for extubation after giving or completing the EHSUAE method, if you feel the baby is still sedated because of the fentanyl effect, what we used to do is to give Narcan or naloxone. And this will make the baby wake up from the fentanyl effect, and then you can just go ahead and extubate the baby. And we did that last time with one of our babies, and it works just fine. Like after giving the fentanyl, the baby was still sedated for some time, and then we decided just to go with the Narcan. Within less than 5 minutes, the baby woke up, and we managed to extubate the baby. So these fine-tuning, very detailed things during the LISA might have a lot of impact in the future of BPD for these babies. So every single detail matters for this baby, and I would just go and look for other people's experience, and you can see we can learn a lot from them. Thank you.
Thank you, Dr. Yasser, for your comment. I totally agree with you. Any patient will plan for intubation him if it's not emergency. Yes, please give him the rapid sequence of atropine, fentanyl. Here we are using recuronium, so it's different protocol. But any patient you decide to intubate him electively, please sedate him because, as we said, it will prevent the fluctuations. Other things, yes, I agree with you. If you can keep him, if you have the experience had that you can keep him on. Any patient we give him Cervanta invasively all the time. We use the manual breath through the mechanical ventilation. We stop disconnecting the patient from the machine. We connect him and we give manual breathe through the machines to keep the PEEP, so you will not lose the PEEP. For EHSUAE technique, you can keep him on non-invasive ventilations, give the Cervanta and pull the tube. But difference from school to school, as Dr. Hada, he's connecting him to the ventilator and give manual breath, and then maybe if he's ready, they took the tube. And why I try to avoid this one, and الشباب هنا, if they connect, they kept him for 2-3 hours, So I want them just to learn to give the EHSUAE technique and to pull the tube later on. Thank you. Any questions? Any comment?
The question is the same question. If you give the fentanyl.
Can we say any questions? So thank you, everyone. Thank you. مع السلامة.
Thank you.
Thank you, Dr. Amna.
شكرا دكتورة آمنة. Thank you.
Next week.
Thank you, دكتورة آمنة.
السلام.
لا ممكن تروح لنفس الموضوع.
لا عشان